Good evening, everyone.
Good evening.
It's nice to see you, Michelle. My name is Tamer Al Tayem. I am an assistant professor at Al Hashimite University. I will trust that I will leave the lead with the student.
Good evening, Professor Michel. Thank you for joining us today and to discuss multiple sclerosis and share your knowledge. We are third-year physical therapy student at the Hashimite University, certainly studying neurology with Dr. Tamer Tayem. While researching multiple sclerosis, we came across your work, which inspired us to reach out and learn from your knowledge. We appreciate your time and look forward to asking a few questions to benefit from your experience. Thank you again for accepting our invitation.
Welcome.
Thank you for that introduction. Hello everyone, I am Aya, and I'll be discussing the pathological and physiological aspects of multiple sclerosis, beginning with what MS is. It occurs when someone's own immune system accidentally attacks the central nervous system. The immune system primarily targets the myelin sheath in white matter. This process happens in a recurrent pattern, causing scarring and plaques in the affected areas. As a result, there's a nervous system impairment characterized by delayed processing of impulses, which can lead to fatigue even during normal body functions. Physicians usually confirm the diagnosis using the McDonald criteria. MS is most commonly observed in people aged 20 to 40 years old, with women being more frequently affected. Unfortunately, there is no cure for multiple sclerosis, meaning patients will live with the condition for the rest of their lives. However, one of the first-line therapies for MS that helps improve the quality of life is physical therapy. We, as physical therapists, play a critical role in managing the condition by providing well-structured guidance to prevent complications and enhance physical function.
Each student of us have his own questions about different symptoms and impairments.
Great.
So we design a single case for each of us, and like to arrange one by one.
Hello, I'm Omar Shawish. Today I'm going to discuss the psychological status of a patient. Now my case is a teacher working in a school with primary progressive MS, and we know that the patient of MS can be discriminated by others. This could be students in our case, and this can affect her psychological status and passion of activity of daily living and social life. And all of this can lead to depression and anxiety. Now, my question is, what is the best way and how can we as physiotherapists deal with this status and manage these effects and reduce it as possible as we can?
Great. Okay, so how to help this, I presume, youngish woman with primary progressive MS who's a school teacher who experiences discrimination. So I think I'm going to begin with the issue of primary progressive MS. So if we think of MS, it really falls into three big batches. Relapsing remitting MS, which is the most common, and that's about 85% of people who are diagnosed with MS initially have relapsing remitting MS. They have symptoms of MS, that's a relapse. These last for a few weeks and then go away for months to years, and then may come back with a new symptom some years later. And those relapses keep happening every few years. That's in contrast to the patient you mentioned here with primary progressive MS. So she has symptoms that rather than coming and going, come and don't go away, but just gradually get worse. This is a little harder to diagnose because these things tend to come on quite gradually and are somewhat insidious. They're sort of there, they're gradually worsening. This tends to happen a little later in life. So relapsing, remitting, typical onset 20s to 30-year-olds. This is more like 40 to 50-year-olds. So it's harder to pick up. And then just to sort of complete the picture, the other kind of MS is secondary progressive MS, which is people with relapsing MS. After about 10 to 15 years, the relapses start to get further apart and eventually go away, but they are replaced by a gradual progression of symptoms. That'll happen a little between relapses and then eventually just take over. So in the world of people with MS, just over half actually have relapsing MS and just under half have progressive MS, either primary progressive, they were progressive from the beginning, or secondary progressive, they're progressive now, having been relapsing before. So why does this matter to you? You might go, well, we have lots of medications that actually help patients with relapsing MS have fewer relapses and have slower accumulation of disability. What we don't have is medications to help with the progression of MS. So those patients, even more than those with relapsing MS, really need physical therapy because we don't have medicines to slow that progression. Physical therapy probably doesn't change the progression of the pathology, but can make huge impacts on improving people's function, which is what we as physical therapists do. So if we take this woman, the first thing to do is do a really thorough assessment to understand what her challenges are. Are they with fatigue? Does she need energy conservation? Are they with ambulation endurance? Does she need fitness exercise or just education as to what to do? What can she do? What can't she do? Does she need a cane? Does she need strengthening or balance exercises? There are so many things that MS may affect. You really sort of have to go down and check each one and then come up with solutions for each one. She may have bladder problems and either need a urologist or pelvic floor physical therapy. So lots of different ways to help her. Really, the biggest issue is the thorough evaluation to then hone your treatments to her issues. And then I think lastly to remember that given this is a lifelong progressive disease, you're not likely to treat her and then send her off into the world never to be seen again, but to keep and maintain therapy with her as her needs change.
Well, now Jessica is a patient who was diagnosed with MS, suffers from various motor impairments, including spasticity, which affects the lower limbs the most, as well as muscle weakness that extremely impacts daily activities. These impairments lead to difficulties in mobility, coordination, and functional independence. We as physiotherapists, how would we strengthen weak muscles without worsening the spastic muscles? Or is there any treatment should be avoided in this case?
Excellent question. Always been quite controversial is what happens if we try to strengthen muscles that have spasticity? And certainly there was a time when we thought that strengthening spastic muscles was going to make them worse. Actually, the data suggests quite the opposite, that the problem with spasticity, along with reflex excessive contraction, is poor motor control, which is worsened by weakness. So despite spasticity, you should still strengthen muscles. Clearly, you don't want to keep triggering spasticity with fast stretch, so you need to think about how you might do this. You might use more isometrics rather than fast movements in order to avoid triggering spasticity, but you actually do want to strengthen both the spastic muscles and their antagonists to optimize motor control, not avoid strengthening spastic muscles with the fear that you would make them more spastic. Any questions in that regard?
Thank you, doctor. Which brings me to my next question. Sarah tells us she's been experiencing difficulties with her vision because of her multiple sclerosis, and she wants to know if her risk of experiencing more vision problems or losing her vision altogether is high, and whether there's anything she can do to make those outcomes less likely.
So she has visual problems. A little would depend on what those vision problems are. In general, people with MS, so visual blurring, double vision, and she has a history of optic neuritis. So in general, people with MS do not completely lose their vision. So they do not go blind. So I would be reassuring to her that that is unlikely. I didn't catch if she had relapsing MS or progressive MS, but if she has relapsing MS and hopefully in the future progressive MS, being on MS disease modifying therapy, so medication, reduces her risk of recurrent optic neuritis, each time worsening her vision. But in general, with optic neuritis, vision does improve after each relapse. Often to baseline, although not always. And she may experience worsening of vision if she gets very hot, and that heat can happen during physical therapy with exercise, and is actually very not concerning. This doesn't mean it's going to stay that way, but increase of core body temperature or increase of optic nerve temperature will temporarily worsen vision, and thus might be worrisome to the patient, and reassurance that that's temporary while she's warm. So exercising, she might do better exercising indoors than outdoors if the temperature is hot, using a cooling vest, exercising in a pool, anything that stops her getting overheated, at least will stop this temporary change in vision that can be both functionally impairing and worrying, but isn't actually damaging. And she should obviously be under the care of an ophthalmologist, an eye doctor.
Hello, I am Husni Shatat, a
Hi.
physical therapy student. I really appreciate your time, and I read some of your research, and I read your book about physical agents in rehabilitation that teach me a lot. Thank you.
You're welcome.
Now, regarding to multiple sclerosis, we might expect some vertigo, some dizziness associated with our patients with multiple sclerosis. And in case if my patient have central vestibular disorder associated with multiple sclerosis, which reflects vertigo, worsened by and body movements. And I checked for peripheral vestibular function and found that he had signs of pinging paroxysmal positional vertigo. I'm wondering, in this case, what should I treat first, and what are the instructions for my patient?
Interesting question. So what I'm hearing is your patient has postural instability and signs of benign positional vertigo, BPPV. So interestingly, BPPV is not actually a symptom of MS, because MS is affecting the central nervous system, so not the 8th cranial nerve, but patients with MS are more prone to BPPV than other people, so they are at increased risk. So it's an association, but it's not a symptom of her MS per se, if that's what she has. And actually, you would treat her just the same way you would treat anybody else with BPPV. So Epley maneuvers, and then if that doesn't completely relieve the symptoms, all of those other eye wiggly vestibular exercises that you would do with someone with vestibular dysfunction. But I would caution you to just see if there's also other aspects to causing her postural instability, balance problems beyond vestibular problems.
So there is another question related to this case. Is it beneficial to teach the patient and improve his reliance on somatosensory, postural control, and his motor control for balance?
Excellent question. And the best questions are often the ones without clear answers. So it depends. I would tend to say if you can, quote, fix the vestibular system, so if an Epley maneuver relieves her symptoms or his symptoms, you're done and you fixed it. That's better than trying to teach how to compensate. But if you can't fix it, then the next solution is, right, let's learn how to compensate by relying more on vision and somatosensory.
So it's patient dependent.
It's
What is
patient
good for my
dependent.
patient?
Right, and I would try to fix the vestibular problem first, because that gives the person the most normal function and the most systems to work. But if you've tried that for a while and aren't getting anywhere, then you go, okay, this is broken, I can't fix it. Let's teach you to use what you do have to optimize your function despite a broken vestibular system. That make sense?
All good.
Thank you.
Thank you.
Hey, welcome, Dr. Michel. My name is Lubna Samara. I am going to ask about sensory impairments. So if we suggest that a patient is coming to our clinic and his symptoms about burning and tingling sensation in both lower limbs, described as walking on hot sand, occasional hypersensitivity to touch, where even light clothing feels uncomfortable, increased irritability and fatigue due to poor sleep caused by discomfort. So my question is how we can deal with patient having pain from unpleasant stimuli and applicate our intervention smoothly.
These patients we see them, it's really tough. We tend not to have great treatments for sensory problems. So things you can try. I'm going to look at your sort of itching, fiery pins and needles symptoms first. I'll look at the electric shock symptom slightly separately. But for those three, sort of these general discomfort that might vary, sometimes TENS is effective. Sometimes constant forms of stimulation are effective. And then sort of at the other end, sometimes they find sort of numbing creams, lidocaine can be helpful, but it's not an easy, I don't have great solutions for these things. I'd say TENS is the most likely. The electric shock thing, you want to separate out a little bit because you do have patients who get electric shock symptoms as what's called Lermite sign when they flex their neck, and that's pulling on their spinal cord. And that's a little different from just zaps that are happening randomly. If they have Lermites, this again may be treatable by the physician with steroids if it's acute, or otherwise at least to understand that it's neck movement that brings it on. But yeah, we don't have great treatments for sensory symptoms.
If we give them a medication, if there will be negative symptoms, how we can deal with them? Is there be negative symptoms in other for the MS patient?
When you say negative symptoms, do you mean side effects or do you mean loss of sensation or loss of something?
Or motor weakness, for example.
Oh, okay. From the medicines or just the medicines, or are there medicines that help?
Just from the medicine.
So certainly one of the problems with medications in MS, this particular, not really the disease modifying medications don't tend to make people have worse symptoms, and if they do, they change them. There's a big choice. The symptomatic medications can often make people drowsy, sleepy. They don't tend to make them weak per se, but they certainly can make their fatigue worse. And it's really a matter of working with the patient and the doctor is there a dose of medicine where the benefit is greater than the risk, than the downside? Sometimes there is, sometimes there isn't. And then the patient gets to decide if it's worth taking that medication or not. I think one of the things that just becomes clear as you practice for longer is we all have the ideal of taking our patients and making them perfect again. And the reality of treating these progressive chronic long-term diseases is, I tend to find both medicine and physical therapy almost always helps, but rarely gets somebody back to the way they used to be. So we just have to also set realistic goals for ourselves and for our patients. We should be able to nudge things in the right direction.
Michelle, can I ask one thing?
Sure.
You know, when you are dealing with someone who are, let's say, diagnosed with multiple sclerosis, and if he read about his condition, then his psychological state will be, really devastated. So as a physiotherapist, when you are dealing from your clinical experience, when you are dealing with a patient who is maybe not willing to accept the fact that his condition is getting worse and worse day by day, and how to make him motivated, if there is a certain approach that you follow with those kind of patients, we will be more than thankful if you can share it with us.
Sure. I think it's very individual and it varies, and I'll give you some examples. I certainly see, not uncommonly, newly diagnosed patients who are very upset, depressed, worried, scared, that they're going to end up sort of like the what I would call the poster child of MS, somebody in a wheelchair, disabled, unable to do anything, taken care of by other people. And what I think is really important is to let them know that really that's not most MS. In fact, today that's extremely rare. And that part of it is that most people who have MS, nobody knows they have MS because they're so normal. And that with good rehab and good medications, the overwhelming majority of people with MS live a normal lifespan. They don't end up in a wheelchair. They work probably as long or close to as long as other people. They are able to have children. It doesn't affect fertility at all. So depending on what their priorities are, that their lives can be very close to normal despite having MS. So that's one end. There are people who are college professors, judges, whatever this person wants to be. There are people with MS doing it with very little problem, except that they do have to take medication. Or they might fatigue a little earlier and stop a little earlier, but really pretty minimal. And at the other extreme, just to be clear, I've also had patients who really, very few, but there are patients who really, really don't do well. And you really, really don't have options. And then you have end of life discussions. So those are usually, that's not PT's discussions, those are physician discussions. And that's going to depend on the law and the culture that you live in as to how that gets dealt with. But I've certainly encountered that. But it's vanishingly rare. And for most people, sometimes support groups are helpful to meet other people. People can get very isolated, and to see other people managing this. I think a really important piece for the students in particular is to realize this isn't what I would call a team sport. MS affects a lot of different things. You as the PT, it doesn't matter what, I'm not going to do this alone. So you're working with the the neurologist, maybe a rehab doctor, maybe an ophthalmologist, maybe a psychologist, maybe a psychiatrist, maybe a social worker, that there's a whole team of people who can help support the patient and work with them.
Thank you for that, Michelle.
You're welcome.
Who's next, please?
I have another question.
Go ahead.
Well, okay, a young lady was diagnosed with cerebral multiple sclerosis is suffering from dysmetria, which affects her ability to judge the distance and affects her activity daily living. We focus on coordination by practice finger to nose or heel to shin exercises, and balance training by performing single leg stands or walk on a straight line to enhance stability. Now, how can a person diagnosed with dysmetria with it? Or are there any strategies to reduce their impact on activity daily living?
Often this is a good place to work with your OT on weighted tools, because sure, you can try and practice to get better at whatever this impaired function is and hope with that it'll get better. You can hope that her brain gets better and that she learns, but compensatory devices can also often be helpful.
Can I ask a question too?
Sure.
Now, if we have a patient with double vision or any other vision disturbances, and in the same way, they have a proprioception and joint position sense impairments, and we know this patient could have a really big problem with gait. Now, what we can do for this patient? Should we do balance exercises? And we also know he will most likely have fatigue and muscle weakness. So what should we fix first? Yeah, I mean, should we begin with balance exercises or muscle strengthening or vision treatment?
A little bit depends on whether this is acute or chronic. So if this is an acute relapse, I'd actually wait until it got better, give it some time, and then see what's left to sort of pick up what remains. But if this is a more chronic situation that you don't think is going to resolve with time, often diplopia is often most easily dealt with an eye patch that you switch from one side to the other, so you don't have to worry about both eyes at the same time and coordinating them. So far as gait is concerned, if you have proprioceptive loss, often what can be helpful is even just a light cane or a hiking pole. Anything, I always say it's sort of like a blind person. You're not really using it to support weight, but you're using it to get somatosensory information up to the cervical spinal cord instead of trying to go through the legs and then all the way up through the thoracic cord. So just a shorter distance, fewer plaques, more likely to get there. To give the and just extra data, somatosensory data about position in space, and then work on that.
So the cane will help the patient in the proprioception, proprioception, and then we can work on the other symptoms. This is what you mean, right?
Right, and often that'll help also with their fatigue because now they're not working so hard to walk and not fall over. And even just light, I think an important thing is to teach people to put light pressure on the cane, not try to put their weight into it to hold them up, but just some light pressure for sensory input. And often they can tell the difference of just standing and just even touching the wall and how much more stable they'll get.
Okay, thank you.
Another question quickly at a treatment approach. When facing fatigue of multiple sclerosis, which is the most popular symptom, what is the evidence or efficiency of aquatic exercise and breathing exercise? Is it a must in the session?
And for better or for worse, we really don't have good evidence for anything for fatigue and MS. So we have bad evidence for lots of things, and we tend to therefore take a trial and error approach. So there's nothing that's a must. You try something and see if it helps. And those things vary from exercise, aerobic exercise, energy conservation, various medications that all the evidence say don't work, but some patients report that they do. So you're really sort of individually trial and erroring all the things that might work, but we have no good evidence that any of them work.
Okay, very good.
Okay.
Thank you very much.
You're welcome.
Okay, thank you, Professor Michel, for being with us.
You are welcome.